I'm here with Jeffrey Singer, a senior fellow at the Cato Institute. He also works in the Department of Health Policy Studies, and he's founder of Valley Surgical Clinics, the largest and oldest group private surgical practice in Arizona. He's been in private practice as a general surgeon for more than 35 years. Jeffrey, I don't think I've finished reading all your bona fides, but welcome. I don't know if we have time for all of them.
Well, thank you for having me here. I always enjoy talking to you.
Yeah, you too. I've been really interested in your work too. Can you tell people, you've been on the show before, but we've revamped the show since last time you were on, and I don't know, I've definitely absorbed some new listeners, and I don't know if they've gone back and heard everything. So just so it can stand alone, could you talk about your work and how you came into it and what you do, both
Sure.
on the Cato side of things and policy side of things and as a doctor?
Yeah, sure. Actually, it was almost exactly a year ago that we had our last talk. So I'm originally from New York City. I'm a general surgeon. I went to medical school in New York City and came out to Arizona to start my practice. And I've been in practice since the early 80s as a general surgeon. I started off all solo, which was the way it was done in those days, and gradually merged with two other solo surgeons. And we created the first group general surgery practice in Arizona, and it grew. And now I'm the old remnant from the original three. And we have 11 surgeons and nurse practitioners and physician's assistants. We're a large group, but I was always very passionate about public policy and political philosophy. That was my other love. So probably over 30 years now, I would do some work in the public policy arena. I was an adjunct scholar at the Cato Institute for many years. And then it was kind of like part of my life's plan. So as I reached this stage in my life, I'm in my late 60s, I spoke to my partners in my practice, and I said I'd like to back off to just working part-time and no more night call or weekend call. And then I contacted my colleagues at the Cato Institute, and I said I'd like to turn it up a notch to full-time instead of an adjunct. And so I've been a senior fellow now because I'm a doctor, of course. I'm in the Department of Health Policy Studies, which is a natural fit. And in that department, that takes me into lots of different areas that intersect with health policy, everything from FDA reform to health insurance reform to the war on opioids and the drug war in general, to harm reduction. There's a whole lot of areas that healthcare comes into play. And there are other medical doctors who work at other think tanks, but most are not still in active clinical practice, and I am. And I like to think, and I guess I persuaded my colleagues at the Cato Institute that helps bring a different perspective. In fact, I was discussing with a person who wrote to me at the Cato Institute about the COVID pandemic policy. And what I mentioned, because I'm sure we're going to get into this later, but the person said, and you hear this a lot, well, why should I listen to your opinion about pandemic policy? You're not an epidemiologist, you're a surgeon. I don't go to a podiatrist to get advice about my eyes. And that was a good question. And I pointed out that, first of all, epidemiology is a part of medical science and medical education that kind of works into the practice of medicine. I'm not an anatomist either, but I have to know anatomy to be a surgeon.
To do surgery, yeah.
Right. But there are PhDs in anatomy who taught me anatomy when I was, in medical school. So first of all, epidemiology is part of what we do, and we have to kind of keep up on that. Another thing is that as a doctor, I have to know how to and continue to read medical science journals, and I can read them critically and digest and understand the data and the concepts. But then I think that something that may make a clinical doctor a little different. Many, if not most, epidemiologists don't directly involve themselves in patient care. They're more, it's more of an academic sort of research-based focus. Whereas those of us who practice medicine have to help patients every day navigate through real life decisions involving significant trade-offs, some of which could be agonizing trade-offs. So since we are always having to kind of help another human being make a choice that involves trade-offs, I think that may make clinicians have a different kind of appreciation for some of the epidemiological issues at stake. It's one thing for a person who doesn't have that kind of human experience to say this would be the best way to address this problem, whereas a person who has to deal with people who have to deal with the consequences of that, we tend to come at it a little differently.
So you think the major problem is that we are now necessarily involving statistics and human individuals in the same conversation, whereas we haven't really felt the need, such dire need to do that before. That is, we have to talk about statistics. We need epidemiologists. They're good for the field. I'm surprised you even engaged in the argument about authority, but you had a good answer, so I'm glad you did. You're patient enough to do it. But I hear all the time people are sort of code switching between talking about what's important statistically and then what's important in their own lives. Like, how could you say this thing, my life doesn't reflect this policy that you're talking about, would be interesting, where that same person might say something like, well, look, hundreds of thousands of people are dying. How could you say that this policy, you know what I mean? So people switch back and forth between statistics and personal engagement. How do you reconcile that?
Well, I think it's important to be holistic in everything, not just in the medical arena, but I think that's one of the things that separates clinicians from what's often referred to as the basic scientists in the healthcare field. So because if the dispassionate decision tree as to what to do for a particular situation may dictate one particular action, but when you're having to deal with another human being who's got their own issues going on in their own context and who has their own value hierarchy and may have different priorities, clinicians have to deal with that. Yep. So there's a tendency for a clinician to, when they hear something, a medical policy prescribed, to think, okay, that's easily said, but let me tell you what I'm going to have to deal with when I'm trying to help patients do what you just said I should have them do. So I'm just saying it gives you a different sensitivity, a more nuanced appreciation for things. As far as pandemic policy is concerned, there's another thing that I happen to have made a point about, and I think a lot of people are making a point about. There's more. It's kind of like the same. It's similar to the same point. When you ask a public health official, what's the best way to control this epidemic or pandemic, they in their lane that they work in, they're focused on, this is the pathogen, this is the way it moves through the world, and this is the way you control it, which is fine. And I want to know from those people everything I need to know about how this pathogen works and what's the best way to control it. But they are not economists, they're not sociologists, they're not political scientists or psychologists, and they don't pretend to be. So I think there's a real danger among our leaders in general, in all levels of government, because they've had a tendency, particularly this time, to say, I'm basically putting all the decision-making authority into the hands of the public health people, and I'm going to follow whatever they say. But they are not as tuned in to trade-offs. So, and again, to value hierarchies. So I think true leadership requires saying to the public health expert, the epidemiologist, tell me everything you know and what you think I should do. Then after I hear all that, say to an economist, based upon what that person just said, what do you think will be the effects of that? And maybe say to a political scientist and a sociologist, what do you think will be the social impact if I were to follow every one of those recommendations? And how do you think the people who go along with it, do you think there'll be compliance, or do you think there'll be resistance and maybe bad outcomes from the resistance?
So somehow weave in a systems approach that deals with first principles, that thrives on first principles and deals with second order questions.
And a true leader has to ask all those different people who have different perspectives and different expertise. And then that leader has to put it all together and make a decision. as opposed to saying, I'm just throwing it into the hands of these people and letting them run the thing. I think that's dangerous because it's too too one dimensional.
Let's put this out front. You, of course, you're going to have a libertarian bent, but I mean,
Sure.
you work with Cato.
Mm-hmm.
Okay, that out of the way, though. I mean, I've heard you speak very sensibly about this issue, and whereas if I'm not careful and I'm feeling sensitive about something, how this issue with COVID is personally affecting me, then I can easily read something that a critical thinker about the issue is saying, like you, as dismissive of something. If I go back and read it on a different day when I'm less in a less emotional state, I can read the same thing that you or someone else who's critically thinking puts out, and I can, even if I could agree or disagree, but see the value in what you're doing. I think that I've seen that everything that you've written about the topic is thoughtful in the way that you just described. What's your take? It's too big of a question, but give me some of your take, your ideas about this COVID response. You know, what's been good, what's been disastrous, and what do you think we should do moving forward?
Okay. Well, first, I'd like to start off by saying, as a libertarian, I could say that if there's any legitimate libertarians believe in very limited government, of course.
Yeah.
If there's any legitimate function of government, it's to deal with a public health crisis like this. So this, so nobody here is saying the government should stay out of this. So this is what you want.
Yeah.
A government to be able to. This is when you want it to come in. It's
Actually, sorry. Could we just
Sure.
plant a flag there for a second? Because people might have confusion about what libertarian means, and I know that people define their own libertarianism differently. So you're not an anarchist by any means?
Not an anarchist. I'm a minarchist, some people say. A limited government libertarian, which is what most libertarians and what the Cato Institute is. Some people use the word classical liberal to describe libertarianism. Liberal in the classical sense. In a lot of the rest of the world, libertarians are called liberals. It's kind of an American neologism.
Got it. Sorry, I don't want to bog us down with that, but it's interesting to get that out of the way.
Yeah. So first of all, it's easy to do a lot of Monday morning quarterbacking. When this thing first hit us, we didn't know a lot, and so everybody was trying to find out whatever we could find out, and there were mixed signals. So to be fair, now we're just talking broadly here. To be fair, when we knew this is a brand new virus that nobody had been exposed to, that we had very good reason to believe it was more deadly than the common flu that we contend with every year, for example, and that it seemed to be spreading very rapidly, I think it was reasonable, until we learned more, to err on the side of overcaution. But then now it's about over 7 months later, close to 10 months later. So we've learned a lot since then. And we also know that our initial efforts to kind of lock everything down, like I say, well, at the time, I don't want to criticize it because it might have been the right thing. What we've learned since then is that caused a lot of economic and psychological damage. Some of it may be lasting damage. And depending on who you are, it's very easy for people who could make a six-figure income remotely to say, stay inside, and rely on, lower income people who have to go to work to take the risk and, deliver the food to your house or whatever, or work at the cash register in a supermarket. So now that we know a lot more, we know, number one, that thank goodness it's not nearly as fatal as we thought. Number two, it seems like for the great majority of the population, I'm talking about people under 50, it's actually either roughly equal to the common flu, or even, depending if you're very young, safer than the common flu. But then for people over 50, they're the ones who are at risk, particularly those who have pre-existing vulnerabilities. And we've now been able to identify a lot of who those people are. So with that in mind, like I said, we have to keep in mind trade-offs. We've seen countries that have locked down a lot longer than we did, and we hear, as we're recording this, Europe is having a new surge in cases, and they're beginning to lock down again. Well, it looks like you can't keep going through locking down completely, then opening up, then locking down, then opening up. That's too destructive to society as a whole. So what I would advocate for is a more nuanced approach, targeted towards protecting the people that we know we need to protect. For example, a great majority of deaths early on took place in nursing homes, and we did a terrible job of protecting those people.
Yeah.
We also know most of the transmission occurs indoors in enclosed places. Probably one of the reasons why it's picking up steam again right now is because as weather's getting colder in the northern hemisphere, people are going back indoors again, and so that's easier to spread. We know, well, it's clearly not a panacea. Mask wearing definitely helps, although the CDC has told us something like 80% of people who've gotten COVID got it despite the fact they're wearing masks as directed. So it's wrong for people to think that they're safe with a mask. It helps. And so we know the things that we can do. We also know that there are a whole lot of other people that we don't have to quarantine the healthy. We should be quarantining the sick and contagious and protecting the vulnerable and trying to let as many people as possible get on with their lives, because we're causing a lot of, again, these are the trade-offs that economists are always thinking about trade-offs. Everything, a cost is what you give up in order to get something. The price is what you pay, but the cost is what you gave up to get that. So, we're seeing, as a doctor, I'm seeing increased number of people showing up in hospitals with advanced cases of conditions, whether they're cancerous or non-cancerous, but showing up in situations that we haven't seen them showing up with in years. A simple thing like appendicitis, we commonly see people show up in the emergency rooms now with a ruptured appendicitis that may have ruptured days ago, and they're on death's doorstep. We've had to take care of them in the intensive care unit because they're septic from peritonitis. And it used to be rare to see people show up like that. They usually, they start getting pain, they get medical attention right away, but they've been staying away because they're afraid they're going to catch COVID. And of course, a 20-year-old's risk of dying for COVID, I think the latest numbers from the CDC is 3 in 100,000. Much greater chance of dying from appendicitis. So people are not, putting things in proper perspective. So that's part of the trade-offs. We're seeing delays in diagnosis of cancer. In the area that you work in, people with substance use disorder, we're seeing, first of all, increased use of different chemicals, alcohol, et cetera, because when you're isolated and lonely, I don't have to tell you, you're an expert on this. People
Go ahead.
Who are suffering from substance use disorder, connection is very important. And if suddenly you're isolated, that's the opposite of what you need at that time.
Yeah.
And then chronic pain patients are finding themselves unable to get appointments with their doctors, and medical practices also are suffering because patients have been, in the early days, were told to stay away, and now they're afraid to come. So a lot of medical practices are actually shutting their doors. We're seeing increase in drug overdose deaths, physical abuse, domestic abuse. These are all parts of the trade-off. So with what we know 7 to 10 months later, I think there's no justification for resuming the approach that made sense or may have made sense, in March and April. And so we should take a much more nuanced, focused approach. And a lot of people deride that as saying, well, you just want to let it rip until we reach herd immunity. No, I'm not saying I want to let it rip. I'm saying that there's some people that we really don't have to make these sacrifices. And and a lot of young people, we're sacrificing their futures. And we need to take these things into consideration.
For sure. What would it look like to let it rip? I mean, if we did nothing.
To do nothing, I think we'd see many more people dying because nobody would be paying any attention to trying to reduce spread. So, for example, I think it makes sense if you're a teenager and you want to party with your friends because you know that even if you were to catch COVID at that party, the chances of you getting, deathly ill is extremely remote. The worst case scenario is you'll, maybe for a week or so, you'll have a terrible flu-like syndrome, which you've been through before. And so you make the decision, I want to, at my stage of my life, it means more to me. I'll risk that to be with my friends and have that social interaction, which is very important. Okay. Well, then because of that, you shouldn't go visit your elderly grandparents for a couple of weeks after that encounter, because you know that you might, even though you're willing to take the risk, they're not willing to take the risk, and you may be subjecting them to that risk. So you're going to need to make some adjustments in your choices and in your behavior, but that doesn't mean you have to be shut in as if you were the person at risk.
What do you think that we just educate the public as much as we can and hope that people make the right decisions, or are any mandates reasonable, you think?
Well, like I say, there you could justify it philosophically in certain mandates, like quarantining,
Yeah.
contagious people. I, my predisposition, my sensibilities are that whenever possible, try to use persuasion rather than coercion, and try to use a light touch. And I think experience has been that in countries where they didn't mandate mask wearing, but they strongly encouraged it, I think people are much more likely to cooperate. There's a natural tendency, particularly, and this may be cultural too, like in America.
Yeah.
And where I live in Arizona, just like in New Hampshire, I think is the other place, you don't have to wear a helmet when you ride a motorcycle. So the best way to get the motorcyclists who wear helmets in Arizona to take their helmets off is to pass a law making it mandatory.
Yeah.
There's this tendency of people saying, I don't want you to tell me what to do.
Yeah.
So it's much better if you could. The other, I think, tendency most people have is people, of course, they're always pathological people, but most of us want to be considerate to our neighbors, and we don't want to be viewed as a threat or a bad person by our neighbors. So if we know that it's the neighborly thing to do, and it's considerate, and it's really no big sacrifice you're making if you're going into a public place to put a mask on. I mean, what kind of sacrifice? You could do that. It's not, I do it when I do surgery. Of course I have to there, but you could deal with that. And so if you kind of present it that way, I think you're going to get more compliance.
Do you think you get more compliance with states if you say you should take careful consideration of this and think about it, rather than pushing for every state to have a mask wearing mandate?
I think so. Where I live in Arizona, the governor has left it up to the cities, and almost every city in the state has a mask wearing mandate. Now, even then, it's different in different places. So in Phoenix, the police, this is where I live, the police have been told, if you see somebody not wearing a mask, they're instructed to go up to them and ask them to please put their mask on. But there's not going to be any ticket or summons or arrests. There's just going to be sort of, almost like a shaming kind of thing.
Yeah.
And this makes sense to me. There's some different places have different rules. In Arizona, you're told if you're out walking, of course, we have a lot of wide open spaces here. So if you're out riding your bicycle, jogging, walking down the street where sometimes you may, maybe 5 minutes before another person passes you on the sidewalk out here, you don't have to wear a mask in those settings because you're not having close social contact with anybody. So go out and enjoy the fresh air. But when you walk into a store or a public building, then you should put the mask on. And then when you go back out to the open air, you can take it off. And you certainly don't need to wear a mask in your car. Who are you going to contaminate in your car when you're by yourself? So, but then there are other places where you have to wear a mask the minute you step outside, or you can get a ticket. So those things, to me, by the way, another thing is the more reasonable the ask, I think the more compliance you're going to get.
Yeah.
Because people are not stupid. People are thinking, wait a minute. So when I go, and I've seen this when I visited, I have family and friends in California, right next to the state next door. So when you leave your house, you have to put a mask on, and you could be the only person for thousands of yards in any direction. But when you walk inside a house, you could be walking in a house with a whole bunch of friends that you invited over, and everybody could take the mask off inside the house. So you got a whole bunch of friends that you invited over to a social gathering at your house in the Los Angeles area. And once everybody gets inside, they can take their masks off. When we go outside, they put it on. So it's like you're putting it on just to show the police you're wearing a mask, but you're actually indoors with a whole bunch of people without masks where you can give it to one another. It makes no sense.
Someone has to be able to say, we should all do what we can to take these precautions as often as we can and the most reasonably we can. But right, to say you're going to run into contradictions if you try to mandate it across the board, because you can't. But
make sense to people. I think sense.
My best example of this is I work in a school system, and one of the teachers was explaining to all the students, you must wear your masks at all times. There really are no exceptions when you're in the building. We can take them off at certain distances when we're outside, and that's a whole nother weird thing that you can get into. But unless you're eating, and then you can take your mask off. And one of the kids said, well, what if I'm constantly eating?
Right.
But I mean, I guess what I'm saying is he was intuiting the fact that, that you're making an adjustment because obviously we need to eat. So you're weighing the risk there. But, there are circumstances in which you're going to run into that. You can't be a Leviathan all the time, or else you're just going to run into just inconsistencies in practicality.
Yeah, I think the role of the leadership should be to give the people the best up-to-date information available. Tell them these are the things that reduce your risk of getting it or spreading it. These are the things that increase your risk. But then, and everybody needs to understand that science is an act of discovery. It's not like a dogma. So what I just told you, I may end up having to tell you something different a week from now because we learned more.
Yeah, and I've noticed that about you, by the way. I can really commend that about you. I've things that you've put out. I see that you make corrections or not even corrections, updates to your beliefs and thinking and views and ideas as you go along.
Well, thank you.
As you should.
That's being scientific. Yeah. So if we explain that to people, I think the majority of people, like I say, they'll do the right thing. And here's another issue I have. So this is, of course, the governors have done this. So when governors get into the business of saying, we're going to only allow essential businesses to operate. Well, what's essential?
That's tricky.
Yeah, what's essential? And we're learning that, for example, supermarkets are essential, but so are trucking. So is trucking because they have to bring the food to the supermarket.
Right.
And then maybe the oil and gasoline people because they need to put the fuel in the trucks. And maybe the guy who makes the bolts that when you have to change a tire on a truck that has a broken wheel or something. So there's so many different. Our economy is so interconnected. Yeah. It really isn't a good idea to have one person or even a committee decide what's essential and what isn't. And then you get all these inconsistencies. So, for example, and I'm just thinking about, here in my own experiences in Arizona, when these blanket rules, 50% occupancy for a restaurant is allowed in Phoenix. Okay. Well, some restaurants, the way they're situated, their tables are definitely 6 feet apart anyway, or their booths. And why do they have to have 50% occupancy when another restaurant where it's much more densely packed has, those kind of things. There's inconsistencies. Different people think it's unfair, and it is. It's unfairly applied. So I can't go to the gym. Well, we can here in Arizona, but let's say I can't go to the gym, but I can go to the supermarket.
Right.
So instead, I think a better approach again would be to get the really good information out there and maybe set up some guidelines so that all of the businesses, essential and not essential, whoever they are, all of the businesses, if you're a single mother and your job as a secretary is what's feeding your kids, you have an essential job. Yeah. Okay. So instead, allow all of us, given this information, to develop solutions with our own circumstances, because no two businesses are alike, no two workplaces are alike, etc. So give me what I need to know, and as long as I meet those parameters, let me work out my own way of doing it, instead of having, you got in certain states, governors are telling you you can't order a drink from a bar unless you order food with it, and chicken wings doesn't count as food. It has to be X amount. That's crazy. Yeah. Just tell everybody what we need, like what goals we have to try to reach, and then let us figure out how to reach those goals. Everybody can come up with a different solution.
So that's what guidelines are really for. I mean, if guidelines are working the right way, then they're offering best advice for businesses to work out on their own. And that gives a business or a place of work an external control to blame. So no one has to say, oh, this supermarket is, they're all Nazis because they're doing this. Like I said, listen, we're trying to do our best to follow the guidelines. And at the same time, you're not forcing any businesses to do anything.
And I think you'll also get much more, cooperation, and people won't get angry and won't feel like they're being treated unfairly.
Yeah, we have been in a state of a lot of people, for a lot of different reasons, feeling like they are not in control of their
Right.
destiny.
And that is not good for the psyche.
Sure. Now, I should have let this some of your previous statements segue us into a white paper that you recently put out. Very thoughtful, very concise. This is a paper that I could have sent to, people that I know who really have no sense about drug policy or anything like that, and would have understood it. But it also is a paper I would send to colleagues, and will, because I'll post it on the web. So it was very well written, and I'd like to explore some of that, because, as you said, the whole operation of lockdowns, things being off limits to us, has put people in a sense, and sometimes a literal sense, and sometimes just a feeling of isolation. People have been, clenching things that make them feel more connected, whether that's the things that aren't people that they get to see. And so oftentimes that's drugs, and oftentimes that's illicit drugs. I mean, people are the death rates right now are ridiculous. If you can ever get around to figuring out how to best count them, they are just absolutely unacceptable, and they seem to be preventable in a lot of cases. So I don't want to, piece through the paper that you wrote one at a time or anything like that, but maybe you can give a 10,000 foot view of some of the policies that policy suggestions that you put forward about how we could allow people safe supply of all sorts of drugs.
Yeah, thank you. And by the way, please, everybody who's watching or listening to this podcast, you could access this, but it'll also be on the website. And please feel free to share it with as many people as you can. It's called Drug Reformation, End Government's Power to Require Prescriptions. Now, and it's interesting because it kind of, after what we just discussed, you could see how this kind of coming from me kind of fits, right? It's the same.
Yeah, you would say this,
perspective.
Yeah.
Yeah. For people probably aren't aware of this, but up until the 1950s, it was considered just it went without saying, like it was, an inalienable. It was self-evident that we all had the right to self-medicate.
Yeah.
In fact, this is interesting. If you ever want to read an interesting book on this, it's called Pharmaceutical Freedom, Defending the Right to Self-Medicate by Jessica Flanagan. That's with one N. I didn't know this, but in that book, she pointed out that in the early days of our republic, Thomas Jefferson was speaking to a group and trying to explain to them why the right to free speech is so sacred. And he said, it's as sacred as our right to self-medicate. That was to help them understand how important it was. And that's ironic because today we'd have to say the right to self-medicate is as sacred as your right to free speech. We've gone completely 180 on this. So up until the 1950s, you could actually go into a pharmacy. In fact, I'm old enough to remember when a lot of our mom and pop pharmacy stores, because they weren't these big chains, they used to call the pharmacist doc. And you walk into a pharmacy and you may have had a prescription from your doctor, or maybe you didn't. And you ask the pharmacist what the pharmacist recommends, or you give the doctor your prescription. In fact, there was a skit, something about this on Curb Your Enthusiasm with Larry David a few years ago. And the pharmacist could even say to you, well, your doctor recommended this. Could I suggest something I think is better? And it was understood that you were going to ask the right questions, and then you're going to decide what you wanted to do. A prescription was a recommendation, but it wasn't a permission slip. It was what this doctor, who's obviously knowledgeable, recommended. And most reasonable people, if it was something they didn't already know about, they would go to an expert and say, what do you recommend?
Yeah.
That's the way it was. But that all ended in the 1950s with what's called the Durham-Humphrey Amendment to the Food, Drug, and Cosmetic Act. So I don't want to get too into heavy history here, but up until 1938, the role of the FDA was just was just to make sure that whatever you were selling was what you said it was. It was like a anti-fraud kind of thing. So if there was if it was adulterated with anything that is potentially poisonous or addictive, so if it had alcohol in it or anything like that, you needed to say so on the label. And they would test it to make sure it is what you said it was and wasn't harmful to people. That was it.
How do you feel about that? I mean, how do you feel? when you say the term addictive, that gets my points my ears up.
I know
already.
I'm using addictive in the historical
Yeah.
sense of the way the term was used. You and I agree. I think there's a big difference between. There is a difference between dependency and addiction is a behavioral disorder. So, but I'm just saying that was back in 1906, the Pure Food and Drug Act. That's what it said.
Yeah, that was tier 1 FDA control or government control over. Yeah.
And I have no, again, in principle, I have no problem with the government making sure you're not defrauding or harming people by selling them something that isn't what you said it is, or maybe even be dangerous. And you're not telling them about some ingredients that may be harmful because you're tricking them. So that's a legitimate function of government again. Then in 1937, the first ever antibiotic had come on the scene, sulfanilamide, which was a miracle because people were dying of infectious diseases all the time. And a company called Massengill in Tennessee came up with what they called an elixir form of the product so that young children or people who had trouble swallowing pills could take it. And the solvent that they dissolved the sulfanilamide in was diethylene glycol, which is chemically related to ethylene glycol, which is antifreeze. So there were 105 deaths due to sulfanilamide elixir poisoning, 34 of them in children. And this was obviously, this is a big national story. And this led to the Food, Drug, and Cosmetic Act of 1938 being passed. And again, I'm giving a real simple version here because we go into much more detail in our paper. But the FDCA basically said, okay, from now on, everything that's already on the market that we could see is safe. This is grandfathered. But any new product that any pharmaceutical maker wants to bring to market has to convince us that it's safe before we're going to allow you to put it on the market. Okay? And they also said that if you're going to market it directly to people, you have to satisfy us that your labeling is clear enough that even a person with a very rudimentary education could understand the instructions. Right. On the other hand, even then in those days, some pharmaceutical makers would say this drug is to only be given to a person who has a prescription from a doctor. Just like we see things like even in cosmetic world or plumbing or whatever for professional use only. And that was a decision that the pharmaceutical company would make saying, you know, this is complicated. Somebody's going to use it the wrong way. We're going to get sued. So let's tell the pharmacist you can't sell this to anyone unless they have a prescription, because then the prescriber is taking the responsibility for explaining how to use it right. So the FDCA said, if you have it by prescription only, then you don't have to satisfy our labeling requirements because the prescriber is going to be the one taking the risk. So that was the law. Then something happened then that wouldn't happen today. A lot of pharmacists, they have a problem where they give a drug from company A to somebody who person just came in and wanted it. So they sold it to them. And then as they left, they were, oh, wait, company A, I'm supposed to sell it to them only with a prescription. It's company B that makes the same drug that I don't have to have a prescription. Right. Getting that mixed. So of course, nowadays with barcodes and everything else, I don't see how that could possibly happen. But so many people may not know that Hubert Humphrey was a senator from Minnesota and later became vice president. He was a pharmacist before he got into politics. And Carl Durham was a congressman from North Carolina, same thing, a pharmacist. So they were sort of the go-to guys for the pharmacy lobby. And they went to them with this problem and they fixed it. They said, oh, they thought they fixed it. So from this point forward, the FDA is going to decide what's prescription only and what's over the counter. We're taking that in the hands of the people. Well, that's the end, of course. Up until then, the right to self-medicate was respected. But now the government is going to decide you cannot have this drug unless you get a permission slip from another autonomous adult like you saying it is okay with me if you have that. And that's the way it's been ever since. Now, there have been a whole host of other regulations layered on top of that we get into in our paper. But number one, not only is this an affront to our right to self-medicate, but it created a whole lot of other problems. And we get into our paper how, number one, there's a lot of really good economic evidence that when drugs are prescription only versus over the counter, they tend to cost a lot more. And when they move to over the counter, the prices drop a lot. A large part of that has to do with the fact that insurance companies usually don't cover over the counter drugs, but they cover prescription drugs. And just like we doctors and the hospitals wildly overcharge the third party payer in hopes that what we end up getting is closer to what we wanted. Well, so do the drug makers. So they'll tend to charge a super high price to the list price. And then if it goes over the counter, then they got to compete with other over the counter products that may not be identical, but similar enough. And then you also have direct payment from consumers who are saying, well, there's no way I'm paying that price for this medicine. Instead, I'm going to buy this other one. And of course, then the price comes down because nobody wanted to buy it.
You gave the example of Advil in the paper, which or ibuprofen in the same
ibuprofen,
thing,
yeah.
in the paper, which was really smart, I thought, because it takes out any emotional connection anyone has with any other drug that they might be thinking about.
Yeah, and we also had an experience that we get to, if you go on the link that you'll put on your website, you can either download the PDF of the paper, which is a paper, or the link. Actually, what we've done is we have what we call a landslide, which is kind of a layout, almost like a online magazine layout. So as you're scrolling down, you're reading the exact same text as in the paper, but there's a lot of interactive charts that pop up,
cool.
videos, and actual commercials from the 1970s and 80s for different drugs that now over the counter. And it's all kinds to make it kind of more interesting and a more enjoyable experience. So one of the things we get into there is, let me see, this is in October of 2019. In fact, I think we even have the video of it in there. One of my colleagues and I from Cato Institute, we had a Capitol Hill briefing with staffers where we were trying to get them to ask to get their congressmen or senators for whom they worked to pass legislation ordering the naloxone to become over the counter. Because as you know, and as we point out in the paper, naloxone is over the counter in Italy, Canada, France, and Australia. And the FDA has said for years now that, you can't overdose on it. If you don't need it, nothing's going to happen to you if you take it. And it's very safe for lay people to administer. And we all know its value to reduce opioid-related overdoses. So let's make it over the counter. And the FDA has actually gone so far as to practically beg the makers of naloxone to make it over the counter by saying, we don't usually do this. This was about 1.5 years ago, but we usually make you fill out the paperwork and get us to approve the labeling for the over-the-counter version of your drug. But we've done all of the labeling and everything. So all you have to do is say, yeah, I want that, and sign, and it's done. And they still haven't done it. Okay? Yeah. And when we had this conference at Capitol Hill for about a week before, representatives of the makers of Narcan kept trying to contact me and my colleagues who were going to be speaking at this conference, wanting to meet us for coffee. I had a great excuse because I said, well, I'm actually in Arizona, so I can't really meet you for coffee. But when I'm in Washington next week at the conference, I'll be happy to chat with you, before or after the conference. So that was great for me. My other colleagues were there, so it was harder for them. They just
sidestep, yeah.
Yeah. So anyway, they after the conference, they were trying to convince me how much better it is to be prescription only, because they said, you see, we charge normally, I think it was $149 for the Narcan spray, but it's only about a $10 copay. So if that wasn't
that was how they were going to convince you.
yeah, because of the insurance. So I said, well, the person who we're trying to get this to, he or she doesn't usually have insurance.
Yeah.
Copay is not an issue. This doesn't help them. And so the point is that they could charge much more when they got a third party. And of course, if Narcan was over the counter, you can get it anywhere. You could be able to get it. You should be able to get it in vending machines. In truck stops, gas stations, they could be selling it because it's over the counter. So we get into the economics of it. We get into there's a whole lot of politicization, because when you have a government entity deciding what's over the counter and what's prescription only, as opposed to the manufacturer dealing with the marketplace, you end up having a lot of decisions made politically. So it took Plan B, the morning after pill, was approved by the FDA in 1999, but it wasn't approved for over the counter for all ages until 2013. It took that long, and it took a court order to get there, because even when an advisory panel of the FDA, I think it was, maybe I have my dates not accurate anymore. It's in the paper. I think it was in the first term of the Bush administration, they recommended that Plan B be made available over the counter for women 18 and older. And the Bush administration resisted, and eventually they relented. And then in the Obama administration, an FDA advisory panel recommended, and the FDA itself signed on to this, recommended that it be made available to women of all ages, because it's safe. It's safer. You know, a 12-year-old could walk into a store and buy a lethal dose of Tylenol, and there is no lethal dose of Plan B. The worst thing that'll happen is it may make you have some vaginal bleeding and nausea if you didn't need to take it. So, and of course, the rationale for making it available for all ages is because you could have a minor female who maybe doesn't want to ask her parents if it's okay.
Right.
Could they take them to the store to buy them Plan B? You know, so the FDA recommended it, and it was nixed by Secretary Sebelius in the Obama administration. Obama famously said, and we have the video of him saying this, "I don't think girls should be able to buy Plan B along with bubble gum and batteries at the checkout counter." That was his phrase. So it took a court order to finally order it over the counter for all ages. Birth control, oral contraceptives, the American College of OBGYN and the American Academy of Family Practice have both recommended that oral contraceptives be available over the counter. It's over the counter in 100 countries, more than 100 countries. So for example, it's over the counter in places like Cuba and communist China, but we choose to, join countries like Saudi Arabia and other countries like that, and keeping it prescription only.
Yeah.
Some states have come up with workarounds by allowing pharmacists to prescribe it, but you have to get permission from someone, and you have to go to the pharmacy. A lot of evidence that women are much more likely to stay on oral contraceptives when they don't have to, get a prescription every time, and when they don't have limitations on how many they can get at a time. So, but why isn't it over the counter, even though you have all of these experts saying that it should be? And it's interesting. It's very telling. If the American College of Obstetrics and Gynecology is saying, you don't need to make an appointment with me and pay me $120 for a visit so that I can give you a prescription for birth control pills, you can go take it on your own. Now that's saying something, because they're actually giving up a chance to make some money. And they're saying, you don't need this, just go get it. Yet it's still kept prescription only. There's politics involved. And then you also have the pharmaceutical companies gaming the system, like I mentioned with an naloxone example. Here's something interesting. See, it's actually because the government's prescribing this government is controlling this, doesn't mean it's making things safer. So let's take the issue of antihistamines. So sedating antihistamines like Benadryl, they've been available over the counter for years. In 1993, Schering-Plough came out with Claritin, which was the first non-sedating antihistamine, and it was prescription only until 2002. Now, non-sedating antihistamines are a whole lot safer than sedating antihistamines. So you can get a more dangerous sedating antihistamine over the counter, but you need to take the time and money to go to a doctor's office and pay for it, and then get a prescription for the safer non-sedating antihistamine Claritin. And here's the even more sinister aspect of it. Schering-Plough lobbied successfully throughout the 90s to get Claritin designated over the counter in Europe. But in the United States, when groups were trying to get it classified over the counter here, for example, WellPoint, the health insurance plan, wanted the FDA to make it over the counter, Schering-Plough argued before the FDA saying, no, it's not safe to be over the counter. You need a doctor's prescription. So they're telling the European regulators, this is safe for over the counter. They're telling the American regulators it's not safe. Why? Because they can get more money charging the insurance companies. Then in 2002, they came out with a new prescription non-sedating antihistamine. And then they actually turned around and asked the FDA to make Claritin over the counter, because they figured with Claritin's name ID now, as the first over-the-counter non-sedating antihistamine, it'll command a huge market share, and they don't need it anymore because they have a new prescription antihistamine. So that's the kind of stuff that happens all the time when you have the decision being made by a government agency that can be lobbied by special interests from all different angles. And then there's the matter of safety. there's a lot of evidence. There's actually really great studies that we cite in our paper. People tend to be much more careful and do much more due diligence when they're self-medicating. And when you think about it, even myself, it stands to reason when when you're going to a doctor and the doctor prescribes something for you, you tend to just figure, well, if the doctor's prescribing it, then it's, and I'll have patients all the time when I'm taking their history and ask them, so what are your medications? They'll say, well, I'm taking this blue pill in the morning, and then there's this red one with a stripe. Yeah, well, what are they? Oh, I don't know. One is for blood pressure, and one is for, I think it's to make me urinate or something. Which is which?
So when they're prescribed, the idea that these things are in your best interest are imposed on you.
Right. Yeah. Yet, when we had that sulfanilamide disaster back in 1937, 95% of the people who took the sulfanilamide, it was prescribed to them. Yep. And if you look at the records, which we dug up a lot of the history, many of these doctors were actually prescribing sulfanilamide for something that wasn't even appropriate to prescribe sulfanilamide for. It wasn't even an infection. And there were documented cases where a mother would call the doctor and say, my daughter's getting sicker. And the doctor would say, okay, double up on a sulfanilamide, which is what the daughter was being poisoned. And this is all, in the record. So just because, and I hate to say this because I'm a doctor, just because a doctor is prescribing it, that doesn't mean we know what we're
certainly
doing.
Seem to be, there's an over reliance on there's a feeling that we need to rely on doctors to solve more problems than they possibly can. I know that I'm a pretty critically thinking guy, but I go into a doctor, and if I feel that something's ailing me and they throw their hands up and say, I don't know, check back in if it gets worse, I get a little annoyed. And so the pressure's on them to come up with something, even if it's not useful.
And sometimes they just feel, let me give me a prescription so they don't feel like they wasted their time here.
Yeah, who am I telling? I'm sure you understand the.
Yeah, sure. It was a really good, on birth control pills, there's a kind of a classic study was done in, I think, 2006 in Seattle by the University of Washington Medical School, where they asked women to self-screen to see if they think they're good candidates to be placed on oral contraceptives.
Interesting.
And the women were in agreement with a team of board certified gynecologists 90% of the time. The 10% of the time that the women and the gynecologists were not in agreement, the women were more conservative than the gynecologists. The women thought, no, I shouldn't take it. And the gynecologists thought, no, it'll be all right.
Yeah.
Now you could ask, is the gynecologist right? Or is the woman right? That's an interesting question to ask. There's no guarantee that the gynecologist is right and that it is okay to take it, because we have examples when that wasn't the case.
What it does tell you is that there's no indication that people will take drugs too liberally necessarily, if they're offered liberally.
So we make the argument now. A lot of people say, well, what if you did that, everybody would be taking chemotherapy and heart med? No, actually not, because especially nowadays, we have so many more complicated drugs for so many things that a lot of it really won't change. For the most part, the pharmaceutical makers are going to say this could be available by prescription. They'll supply the drugstore saying only to be sold by a prescription. They got their liability concerns to worry about. They don't want to get sued, and their reputation to worry about.
Yeah.
On the other hand, without this agency that you have to, lobby for, that makes the ultimate decision, the movement of things from prescription oil over the counter will happen much more smoothly and rapidly. There'll be much more, a much more smooth flowing move. On top of that, there are other options. For example, and we point this out in a paper, in Europe, there's another category called pharmacist only or behind the counter, which is you decide, you don't really need a doctor to prescribe this, but we'd like to have somebody who knows what they're doing before they give it to you. So, for example, in Canada, all insulins are over the counter in Canada. But if you went into, let's say you walked into a pharmacy in Canada and said to the pharmacist, I'd like XYZ insulin product, the pharmacist could say to you, oh, so you have diabetes? And if you said something like, well, I'm pretty sure I do because my friend has it and I have all the same symptoms he does and he's taking that, so I want to start taking that. The pharmacist could say, why don't you go see somebody about that first? I don't want to sell it to you.
Can the pharmacist say no?
Yeah, they could say no. I mean, it's up to them because they also have their own liability concerns too.
Yeah.
So that's a third option. Now, if we ended the government's decision making here, maybe some drugs the pharmaceutical maker may say, well, we don't really need to force somebody to go to spend money to go take time off work to go to a doctor, but we really don't want them to just take it off the shelf with a box of Band-Aids. Let's make this behind the counter so they have to talk to somebody before it's given to them. But that should be up to the pharmaceutical maker to decide that, and that's another option. By the way, a lot of people may not know there are two types of insulin that are over the counter in the United States, and that's because they were grandfathered. So when the Food, Drug, and Cosmetic Act of 1938 was passed, it said everything from this point forward, we have to be convinced that it's safe. Everything already in the market with proven safety is grandfathered, like aspirin. Okay, it didn't have to get approval, and insulin was developed around the time of World War I. And there were two insulin products already out, so they were grandfathered. And then they were originally derived from the pancreas of pigs. In the 1970s, they came up with a way of using genetic modification of bacteria to replicate it without having to get it out of pigs, which helped deal with people who either had allergies or, for religious reasons, some people didn't want to take it. The FDA basically said, well, this is the equivalent of what you've been making, so we'll allow that to continue. So regular insulin and NPH insulin are available over the counter. It's called Novolin and Humulin. And a lot of doctors don't even know this.
Wow.
And it's much cheaper than the prescription insulin. Of course, the disadvantage of a lot of these new prescriptions is that you need to take it more frequently. You need to take check your blood sugar levels more frequently. But basically, up until about the late 70s, early 80s, that's all that was around. That's what everybody was using for their diabetes. And it's much more affordable. I think the product that's manufactured by Walgreens is called Rely On, but don't hold me to that. I think it's the brand they put on it. If somebody were to walk up to the counter in a pharmacy and say, I'd like to buy some insulin, there's a good chance the pharmacy tech will say, well, you got to have a prescription. And then if that person says, no, actually, I don't for what I want, can I speak to the pharmacist, please? And the pharmacist will come over and tell the tech, yeah, that you don't need a prescription for that. And
I might do that just to mess with somebody. Yeah, I might shop stores just to find somebody ignorant about it.
But the pharmacist might do what the Canadian pharmacists do, though, and say, so you're a diabetic? Because they don't have to sell it to you.
That's
so
true. Okay.
Anyway, that's available. Ironically, the two companies that make it, one is based, I think, in Netherlands, and the other one, Novo Nordisk, I think that's based in Netherlands, and the other one is Eli Lilly, and they're based in Indianapolis.
Yeah.
Now, states also could decide to make things prescription only, not just the federal government. Indiana, of all states, to my knowledge, the only state in the union that requires you to have a prescription even for that. And it's kind of ironic because it's made in Indiana, but at least to me, it's ironic. So if you live in Indiana, you can't get it over the counter, but in all the other states, you can.
That's like the deepest irony. Yeah, that's.
Well, yeah, we're talking about that. So when we could segue a little bit into drug war issues, when to deal with the meth crisis in 2005, Congress passed a law making Sudafed behind the counter.
Yeah. Because
it was being used to make meth.
Yeah.
Of course, anybody who's watched Breaking Bad knows there are much better ways to make meth.
Yeah.
But anyway, Oregon and Mississippi passed laws making Sudafed prescription only. So in those two states, you can't even get it behind the counter. You have to get a doctor's prescription. And of course, we all know meth-related deaths are higher than they've ever been now. They're skyrocketing. So
now, I'll just say that
didn't work.
I remember having, what was it, a sinus infection or ear infection or something like that one time, and a doctor, but right or wrong, said, you know what would be good, do this, this, and this, and I'll just pick up some Sudafed, and like don't weasel out of it, just get the strong kind, and take that while you're doing it. So I went, and I remember getting this look like, I asked specifically, what's the strongest Sudafed that you have?
Yeah.
And so,
I know it's great, by the way, it really works.
Yeah.
You have bad congestion. It's a great decongestion. So all we've managed to do is make people who are, sufferers of congestion not be able to have access to a really good medication.
Yeah.
And we've, given the drug cartels of Mexico great opportunities, great market share in the United States, using other like phenylpropanone and things like that. So
let's move into drug policy, illicit drugs, drug policy. How do we make, using everything that you've just described, the logic that you've just put forth, and the ways in which we could reasonably put a dent in the problem of things being too expensive or not accessible or not pure? How do we do that with respect to illicit drugs?
well, an obvious answer is make them licit. For the same reason that we would expect that drug makers they don't want to sell you a poisonous version of ibuprofen because they're worried about their reputation and about getting sued, then makers of heroin or methamphetamine, well, methamphetamine is actually a prescription drug anyway, you can get that. But you know what I'm talking about, all the drugs that are currently illicit, then they're going to be concerned about their reputation as well and not want to sell you impure products. Just like when alcohol prohibition was ended, when I buy a bottle of let's say bourbon, which I happen to like bourbon. So when I buy a bottle of bourbon and it says 45% alcohol, which it usually does with bourbon, it never crosses my mind that it might be 90% alcohol and they're lying to me, or that it's not made from corn and rye,
right?
Because they wouldn't be in business very long if that was the case. So that's the same thing we would have with all these other drugs. And just like you have the right to self-medicate with illicit drugs, I would argue, and I know Jessica Flanagan in her book Pharmaceutical Freedom argued, that you have the right to self-medicate with any kind of drug. Every kind of drug, if it's used in the wrong way, can be dangerous, can harm you physically or otherwise. And the overwhelming majority of people, regardless of what drug they're using, wants to use it the right way. They don't want to hurt themselves, and they use it responsibly. And you're always going to have, you're not going to live in a perfect world. So there's going to be some people who use it improperly or develop an unhealthy psychological relationship with whatever drug they're using. And those people can be helped, but you don't, restrict the freedom and the rights of people to self-medicate, because some people may, make a mistake and harm themselves. That's just no justification. If you just focus on how to minimize the likelihood of harm and to help those people who develop problems.
Philosophically, of course, I agree with you. From a practical policy perspective, which angle do you see would make more sense as a first step to doing this? Attacking, there's already an idea that we should limit prescription opioids, say, or other kinds of prescriptions, because they might get in the hands of the wrong people. And then on the other hand, there are drugs that are just like prescription opioids that are, we want people to be accessing the safest possible version of those drugs. So do we bring up the illicit market so that all those things are legal, or do we take things that are already legal and make them more saleable, more readily available for people, or both at the same time?
Yeah, this is a tough question because, and I think, reasonable people who all share with the same goal to disagree on what's the best strategy.
Yeah.
I think on the one hand, for example, when it comes to our white paper on repealing the Durham-Humphrey Amendment, which wouldn't affect controlled substances that are not allowed to be sold, that's a move in the right direction, because once you kind of break that paradigm, it now becomes easier to discuss other drugs.
Yeah.
But then on the other hand, for example, the movement to legalize marijuana in my state's ballot initiative also coming up next week. But but as more and more states legalize marijuana and the federal government gets kind of pressured to finally throw in a towel on that one. So here's another drug that they told us causes all sorts of danger, yet so many people are using it responsibly. We're not seeing, but we're seeing it be used the same way in which we accept the way alcohol is used.
Yeah.
So, that's another angle to come at it, where you kind of chisel away at drugs that are becoming, that are seen by the general public as being less dangerous, and then work your way up from there. This is probably have to come at it from several different angles. And I'm open to anything that helps move the ball towards the goal.
Yeah, me too.
I'm going to be supportive of.
Me too. I'm always thinking that way in policy. I mean, I get more philosophical and I'm concerned with what's fair or what's maybe sometimes to the dismissal of things that are possible. Like I remember when marijuana in Vermont became legal by prescription, so you get medical marijuana, and I thought this is actually an impediment to to the idea that marijuana can be used ubiquitously in a legal sense, because now we're saying marijuana is fine as long as it's a medicine. Certain people can use marijuana, certain people with certain ailments can use it, but not recreationally, because that would be bad. You get to keep the standard stories, but a couple of years later it is legal in Vermont. So, and that's true across states. So I can't quite tell which comes first, and so I leave it to people like you.
Well, back in the 90s, I actually was involved in, I was a medical spokesperson for the Arizona Medical Marijuana Initiative. And a lot of my libertarian friends were all over my case saying I was a sellout. You say, so you're just going to replace the policeman with a doctor, right? You got it instead
Yeah.
And I said, well, at least we're not putting people, in cages. It's a step in the right direction. But the argument, I became familiar with the argument because I was thinking the same way, sort of like you as well. This isn't that big a thing. But a lot of the people who argued for it said, no, you don't understand. After a few years, when people see that they all have friends or relatives who are using marijuana medically, and they're not becoming, crazed killers or, whatever, all of the other things, that it's not a gateway to more dangerous things, then all of a sudden you just kind of destroyed the myths. And then it becomes easier to go to the next step. And it looks like they were right. That's what's happening, because states that have had marijuana legal for medical reasons are more and more now just taking it the next step and say, why only if you're sick? Why can't you just get it?
And wouldn't that same logic should have applied to opioids, which now are very difficult to get compared to what they were? I mean, do you see that is there some difference there when it comes to opioid drugs? I mean, besides our kind of weird values and attitudes toward them.
No, I think you just got to overcome all of these, this mythology that's been created. Because that prior to the 20th century, even into the early 20th century, you could buy opium, in the Sears catalog. People it was a very common household drug to have in case it was used to treat all sorts of things. And heroin was a cough syrup for children. So it's just a brand. The heroin was diacetylmorphine. So people had a completely different attitude towards these drugs. And that all kind of changed after, the Harrison Narcotics Act of 1914, and then, into the early 20th century. And we had a conference at the Cato Institute about this. It was just a few weeks ago, October 5th, where we get into how so much of the various substances that have been prohibited by law over the centuries, whether you're talking about alcohol, opioids, cocaine, a lot of that was actually originally racially motivated.
Yeah, sure. Absolutely. Well, I want to encourage people to check out that paper, especially the multimedia version of that paper that you were talking about. Tell me one more time the title of it, and I'll link it in the show notes.
Okay, it's called Drug Reformation.
Yeah.
And Government's Power to Require Prescriptions. Okay.
I can't have you here. You're interesting to talk about these things without talking a little bit of politics, especially because by the time this is out, the following day, this will be Monday, so it'll be election day. And so I know a lot of people have voted early already, but people will be taking to the polls, presumably. And I know you also have to be careful about who you do and don't represent when you're speaking on behalf of Cato. But I would like to ask, who are you voting for? No, I'm just kidding. Who do you see wisdom as a libertarian in voting for a third party?
Yeah. No, I do, and I've actually written about this too. I always hear people say a third party vote is a wasted vote.
Yeah.
And if you actually look at the math, now we opened up with statistics, we're going to close with statistics. So statistically speaking, the chances of one person determining the outcome of a presidential election, especially when it's 50 separate state elections plus the District of Columbia, it's been estimated to be 1 in 60 million. So we all think that so often we end up voting for a lesser of evils, that we're not really happy with the two choices that either the major parties give us, but well, this one's worse than that one. In fact, many people this election are going to be voting for the one they dislike the least, as opposed to like the best, because they have problems with both of them. So it's almost like, which of these two will do me less harm than the other?
Yeah.
That's a terrible way, it's a terrible situation to find yourself in. And when you say, well, you don't have to, you could vote. There's a libertarian candidates on the ballot in all 50 states. There's a Green Party. There are other candidates. You could vote for somebody else. They're asking you at this election, out of all of the announced candidates for president, which do you think is the best? And you could actually say who you think is the best, not who you think is not as bad as the other. They're asking you, who do you think is the best? And if you're afraid that your decision is going to determine the outcome of the election, I don't think you need to worry about that. So to me, I just think it's important that I believe that voting, if now this doesn't mean you need to vote third party, but I'm saying if you want to vote third party, but you're hesitant because you think your vote is being wasted, I don't think it's a waste to have it go down in the record that a person, because it's, of course it's a secret ballot, a person took time out of the day up until this year, may have waited in line for an hour, maybe in the snow, to cast the ballot for somebody that they knew had no chance of winning. And they actually took time to do that because they wanted to say, out of the choices I have, this, in my opinion, is the best choice. To me, that's not wasting your vote. That's expressing your opinion. And if instead everybody just picks a lesser to evil, whoever wins, remember, is going to say, I have a mandate. The people have spoken. They love me. They want me to lead them. And everybody's listening to that saying, well, that's not really what I said when I voted for you.
Right.
But so this way, it's clear. If you voted for a third party, then it's pretty clear what you were thinking. So I'm not saying to vote for a third party, but I'm saying if you want to, but you're afraid because you think you're wasting your vote, I don't think you're wasting your vote.
Are you familiar with Brett Weinstein's proposal for the Unity 2020 movement that, of course, he had to pull off the ballot?
I'm familiar with Brett Weinstein, but I haven't heard about this proposal.
So Brett Weinstein made a proposal he was late to the party, let's say, but maybe in June or something like that, to create a new party. He called it the Unity Party, where he would take all of the people that were involved in the party, would educate themselves on the people who just spitball, who are people that you think would make the greatest president this time, who really has the skills, who really could do it. And then they generate votes about two candidates, one from the center right, one from the center left, who they think would be the most reasonable people to govern actually as a team, a vice president and president, but those labels mean very little. They would govern as a team, and then they would agree to, when their term is up, to switch roles, who would call the shots when the other was away or whatever. And so the idea was to, it's like a we the people thing, bring back the vote. And I can't tell how rhetorical it really was or how much he really believed that it could work. I mean, I didn't ever think it was going to work, but I did some research and I talked to people from the movement, and they're very serious about it. And so even Brett Weinstein, who created this whole ballot with a fail-safe, he said, let's say we generate tons of interest, but it's clear that we don't have a viable path to victory, then we will we won't be on the ballot. But by the time anyone can vote, we'll make sure that we can't be on the ballot. So this whole idea was to invite people to just be in this think tank. Like, you don't have to really worry. There's a fail-safe, but if you want to take a crack at this, we could maybe change the structure of how politics is done. So he had this idea. The reason I'm telling you this is because he had this idea that you need to really change things from the bottom up if you're going to change do anything to break the hegemony of the duopoly. But even he the other day, after, now Unity 2020 is done, his candidates aren't on the ballot, but he was talking about how he did a write-in for Bernie Sanders in the 2016 election. He remembers hovering over Hillary Clinton because he just couldn't vote for Trump. He's like a pretty progressive guy. Mm-hmm. And he thought, I can't really do this. So he wrote Bernie Sanders' name in. And then he remembers being, physically removed basically from Evergreen State College by a mob. and then being on, like, trying to get some press from liberal press who wouldn't have him on because the story didn't just didn't quite add up. So Tucker Carlson was the first member of the press to have him on to talk about this weird incident where he was being called a racist even though he clearly wasn't, in Evergreen. And he remembers being able to say for the first time, Tucker Carlson said, well, "You're a liberal. I'm sure you voted for Hillary." He said, "Actually, no, I voted for Bernie Sanders because I just couldn't stomach the idea of Hillary Clinton." And that gave him some footing to talk to both the Democratic Party, who said, ultra progressives who say, "Yeah, Bernie's my guy too," and conservatives who say, "Yeah, we hate Hillary too, so we must have some common ground." So what you're saying here represents that exactly. You're voting for your values rather than voting for the lesser of two evils. Harm reduction shouldn't be for political.
And I don't think expressing your values is a waste. I think it.
No.
Another thing that's kind of, I don't know enough about it yet, but it's intrigued me, is the idea of ranked choice voting, which Maine has recently gone to that, and I think other states are looking at, where you can kind of list in order of preference, and then it's sort of like matching for residency programs when you graduate medical school. So that you try to get whichever has the most votes out of all the options becomes the first. I think that's how it works.
Yeah. I love that idea.
That's something also, and that could be done because that's the prerogative of the states. There's nothing in the U.S. Constitution that dictates that how states shall govern elections. It just says that the states shall elect electors. That's I'm not 100% committed to it yet, but I'm very intrigued by it. It sounds like it might be a good way out of the binary choice that we're always given.
Now, what do you think would be sort of the same question as, we probably agree with a lot of things philosophically, but practically speaking, you invoked ranked choice voting there. Do you see any path out of, I mean, you don't have to give an opinion on this, but as far as I'm concerned, as you say, people are voting for the lesser of two evils. I'm horrified by our choices. And I think so many people are too. It's creating major conflict where people are so suspicious of each other. Do you see any practical way to lessen the detrimental effects of just our two-party system and our candidates that are given to us rather than devised by us?
No, I'm not. I guess I'm just not that wise. I think if you look at his history, we've always thought of our system as like the first past the post system. We always have, two parties, and whichever one. There's always, one or the other. But we've had over time changes in parties. So we had, the Federalists, and then a Democratic Republicans. Right. Then it became the Democrats and the Whigs. Then it became the Republicans and the Whigs and the Democrats. Then the Whigs disappeared. Then it became Republicans and Democrats. So, there is a chance for realignment, and I think we'll look back. We'll know better in about 5 years. But I think we might actually be going through a realignment right now. And this is how it feels, because I think a lot of people who had a tendency to vote Republican most of their adult life are seeing, particularly with the ascent of Trump and the Republican Party, there's being a lot of principles that they as Republicans subscribe to being abandoned. And there, how many examples have we had of Republicans who are now, giving commercials saying they're voting for Biden, for example? But then also we have a lot of Democrats feeling the same way in their party. So maybe this is what it feels like when everything's going, when we go through this kind of turbulence, and then in a few years everything shakes out. Because I'd like to think, and maybe I'm wrong, but I like to think there's basically, instead of saying Democrat or Republican or left, right, or liberal, conservative, I like to think of it as more like authoritarian, libertarian. And of course, there are gradations across that spectrum.
Yeah.
And so some people who are aligned with my way of thinking and consider themselves on the left because we agree with things like on the drug war, criminal justice reform, that kind of thing. Well, I think just a better way to sort people out is, do you generally like to see things where there's more freedom and less coercion, or do you like things where there's more coercion? And, you can go from one extreme to the other on that. But
Yeah.
maybe that's the way things are going to sort themselves out, because, being less coercion doesn't just mean about how you regulate business. It also means how you regulate people's making their personal choices in their life. That's all about, liberty versus authority. So we'll see. Maybe that's, we'll know in a few years whether we're living through a realignment right now. But I'm seeing more and more people not like to identify with either of the two major parties and to have problems with both.
God willing, it's a realignment that'll do us well.
Hopefully.
I wanted to ask real quick before we go. I couldn't remember it at the time, but we were talking about COVID. I listened to Nicholas Christakis. Is that what his name is? Do you know who that is? Yeah.
He's a professor at Yale. Yeah.
Right. Yale sociologist and physician.
Mm-hmm.
He was talking last night to Vivek Murthy about, he was making some predictions about COVID. I think what he was trying to do is just be candid but gentle with people who wanted to know information about COVID and where he thinks things will go. And he wasn't making any blanket statements and telling people what they should or shouldn't do, I don't think, but he made a prediction that, let's say vaccine or no vaccine, if we just kind of do what we're doing now or even less, then when it comes to herd immunity and what we can think about epidemiologically, then by 2022, we can probably see things sort of rescend. And then maybe we'll have to pick up the pieces of economic disparity and things like that as we go. And then he sees that we're headed for like a roaring 20s kind of era by 2023, 2024. That's a very, very potted way of explaining what he said. Do you have any projections like that or any ideas about where you think we're headed, if we make one decision or if we make another?
I think that eventually, I don't know if the vaccines are going to be effective. None of us do, or how long they're going to be effective. I think what's eventually going to happen is that lots of viruses have this natural tendency to mutate towards milder forms because you don't want to kill your host and you need this host to replicate. So I think in a few years, we're going to wind up in a place where it's endemic. It's not going to go away, but it's going to flare up during seasons, just like there's a flu season. But the combination of it having attenuated and us having better therapeutics and knowing better how to live with it, I think we'll just eventually, it'll just become kind of part of life, just like the flu is. That's what I think. But it could take a couple of years.
I know this is not exactly your bailiwick and you wouldn't make these recommendations, but just a hot take. When people are wondering, like, when the hell do we get back to something like what we remember as normal? Do you think that's coming up?
I'm an advocate of more focused protection and letting things open up more quickly.
Yeah.
But right now, I don't think my viewpoint is the majority viewpoint. So
no,
I can't tell you how I can't make a prediction.
Okay, there you have it. We're left with uncertainty.
Right.
Anything else that you want to chat about while we're here and while we have the time?
No, I don't think so. That was a lot of fun. We covered a lot of different.
We covered a lot. Yeah. Please, how can people find more about you, your work, and things that are recent?
You could visit my Cato Institute's website. It's at cato.org. The homepage right now, at the top of the homepage, our study on our white paper on drug reformation is right there. You can easily see it and click onto it. Also, we cover virtually every area of public policy, from foreign policy to monetary policy to health policy, and you can visit all of the different areas there. And if you click under experts, you'll see the different Cato scholars in alphabetical order. You'll scroll down to my name under S. And if you click on my name, it'll take you to my page, which has everything I've written or every media appearance or whatever, everything I've ever done for the Cato Institute is available there.
Which is a lot. You're prolific.
Well, thank you. I try to be.
Dr. Jeffrey Singer, thank you so much for joining us today.
I enjoyed it. Thank you very much.
All right.